So again, thank you for that warm introduction. My name is Thomas, currently an internal medicine resident here at Sinai, and I was fortunate enough to present my work on identifying educational strategies to reduce Hep B and liver cancer disparities within high-risk U.S. communities. Um, at the last IME ERD research day in 2024. So um, I have no conflicts of interest. And this is sort of just a snapshot of my poster, but I'll get into the specifics during this presentation. So before I get started, I just want to acknowledge the wonderful team that I was able to meet and work with going on 4 or 5 years now. I met Dr. Cohen, who's now the president of the Hep B Foundation in Doylestown, Pennsylvania, during my medical school career. And she introduced me to her research team, Beatrice, Kate, Suzanne, Fiona. They're all sort of based in Philadelphia, and most of them are MPH trained, and some of them are getting their doctorates, and they're all associated with sort of this wonderful organization, Hep B Foundation, which I was really fortunate enough to be part of that research team. Um, and we're still publishing some of our work, still ongoing work that needs to be done, but really couldn't do anything without these great team members. So a little bit about my journey and how I got involved with hepatitis B. So it really started back in 2018 during my first year summer abroad as a medical student. I was originally born and raised in China, and as a first generation immigrant, was really interested in the differences in the healthcare setting as well as the healthcare space between China and the US. Obviously, a very broad topic. So I chose hepatitis B as sort of a disease space to look into because we know that hepatitis B is endemic in East Asian countries, China being one of them. So I had the opportunity that summer in 2018 to study abroad in West China Hospital, which is located in Sichuan, part of the Sichuan University in Chengdu, China. I spent about 3 months there shadowing a lot of really talented ID doctors, hepatologists, liver surgeons, a lot of their residents and fellows as well. And overall had an amazing experience there. Really saw, overall differences in how patients are treated there and sort of their throughput when it comes to patients, but also specifically hepatitis patients and how the differences they're treated, and learned a lot from sort of that summer abroad. I brought that experience back to my medical school at Jefferson, and I was fortunate enough to be part of the Pennsylvania statewide viral hepatitis elimination committee, which is a group of doctors, nurses, public health workers, and we did a lot of advocacy work. Writing grants, writing sort of papers to propose basically a state fund towards elimination of viral hepatitis. So that was a really meaningful work that I did in 2019. And then as part of my education, my MD and PH, during my MPH year, also did some work around hepatitis. And that was when I was able to meet the really wonderful, talented, warm team at the Hep B Foundation, where we started work in 2020, 2021, and then we've been sort of in touch ever since and working on and publishing some of these data that we have. So just a little bit of background. Chronic Hep B is a viral liver disease that may have deadly, sequelae such as cirrhosis and liver cancer. However, it is a disease that disproportionately affects certain minority groups in the US, such as Asian American or African immigrant populations, given how endemic it is in their native countries. So I I have here sort of a global picture of the seropositivity of different continents, and you can see sort of the how endemic it is in East Asian countries as well as African countries as well, which means that educating these groups on the linkage between these two diseases, hepatitis B and liver cancer, is imperative in both screening as well as health outcomes, as well as linkage to care for these disadvantaged populations who may otherwise get lost to care or never get screened for these diseases. So this study primarily aimed to identify the knowledge gaps in sort of hepatitis as well as liver cancer and the linkage between the two, as well as looking at preferred mediated communication methods and strategies to overcome some of these barriers and ultimately to promote uptake of prevention and management behaviors of both hepatitis B and liver cancer. These are just some quick data on the epidemiology of chronic hepatitis B. Worldwide, about 300 million people are currently living with chronic hep B. In the US, this was several years ago, but estimated to be about over 2 million, 2.5 million. Over 50% of liver cancer is chronic hep B related, and over a quarter of chronic hep B patients eventually die of liver cancer. The estimated seropositivity for Asian American populations is estimated to be about 10%, whereas the seropositivity for African immigrants about 15%, which is a lot higher than sort of the average US population. So what did we do and what was our research method? So it was qualitative in nature. We had 15 focus groups. This was done in 2021 and the start of 2022. So a lot of them were virtual given COVID at that time. So we conducted 15 virtual focus groups, about 1.5 to 2 hours each. We recruited about 7 to 12 participants for each of these focus groups, and we covered a handful of minority groups, Micronesian, Chinese, Hmong, Nigerian, Ghana, Vietnamese, Korean, um, Ethiopian, Filipino, Haitian, and Francophone West African communities. Overall, about 100, over 100 focus group members gave their sort of powerful voices and data that we then analyzed using thematic coding and analysis to identify themes and subthemes. Each transcript was parsed out by two group members of our team, a primary and secondary coder, and then we ran the kappa to make sure that our analyses were lining up and that final kappa coefficient was 0.78. And we use NVivo 20 as part of our tool for coding and analysis. So what were some of the results? Overall, I think we had, and the most, the biggest takeaway for me from this project was how powerful these voices are from patients and people who may not otherwise have a voice. So, we had um, hundreds of hours of qualitative data, and I summarized it into sort of three broad thematic buckets. The first is knowledge, myths, and misperceptions regarding hepatitis B. Specifically, we heard that patients in these populations have a difficulty differentiating types of hepatitis, as well as incomplete understanding of how Hep B is transmitted. For example, if you see on the right here, a Pennsylvania Ethiopian community focus group member said that Hep B was referred to as bird's disease, thought that it was transmitted by birds or bat droppings, and then it can be healed with traditional medicine. Sort of just encapsulating or as an example of how these patients have a complete understanding of how Hep B is transmitted between people. There was also a resounding sort of stigma and shame associated with Hep B, given that people thought it may be related to unsafe sexual practices, or IV drug use, et cetera. So we heard that as well. And then we also heard that role of fate and inevitability led these people to feel a lack of control over their disease. Things like, if I got diagnosed with hepatitis B or liver cancer, it was predestined, predetermined. Why get connected to care? Why treat it? It was just sort of destined to be, or it was karma from something else. Um, the second thematic category was around liver cancer. So the knowledge, myths, and misperceptions about liver cancer. And some themes that we heard in this category is reflexive association of liver cancer and alcohol, but not chronic Hep B. Most patients that we talk to know about liver cancer, but reflexively think, oh, it's the heavy alcohol use that led to liver cancer. We hardly ever spoke to people who knew the association between chronic Hep B and liver cancer. The exception being we did interview some people who had a healthcare background, whether they're current nurses, et cetera, so they knew the association. But when we're talking about sort of just the average community member, they reflexively associate alcohol with liver cancer. And you can see sort of that example of a quote on the right. LA Korean community focus group member said, I've been told that drinking too much and alcohol can cause liver cancer, and sometimes it can be caused by stress. I know also that, it can have a familial component, but we hardly ever heard these people saying chronic Hep B may be an etiology as well. The third sort of thematic category we heard was sort of the knowledge, myths, and misperceptions regarding the linkage between hepatitis B and liver cancer. And we see that as the linkage remains poorly understood. You can read sort of this quote by a Hmong community focus group member who said that I learned it for the first time when my mom was diagnosed, but I didn't realize that hepatitis B and liver cancer were connected. But it was only until a family or a close friend got diagnosed when they learned about the important connection between the two. So these are just sort of examples of quotes. We have many, many examples that we have collected in our data, so many powerful sound bites, and I can share sort of where we published our data for those who are interested later on. So what do we do about these knowledge gaps, right? What do we do about these knowledge gaps, myths, and misperceptions? So I categorized, you know, a lot of our interviews and focus groups were, half of it was dedicated to trying to find the knowledge gaps, and the other half was looking at, what are some potential communication strategies, and it can really be separated into 5 different communication strategies. The first being whatever we use to approach these minority groups, and the education materials need to be culturally appropriate. Number one. Number two, it needs to be language specific. A lot of these patients, English is a second language. So learning about hepatitis B or liver cancer in their native tongue may hold a lot more weight than just English itself. Community specific social media, knowing how to leverage that as a way to disseminate credible information. We've heard many people using certain minority groups have their own social media, such as WhatsApp, that they use that, the rest of the US may or may not use. So if we want to later develop strategies or education materials, we want to leverage the right social media platform. And the last two are around sort of doctors as advocates, as well as trusted community voices. So these people we heard they want doctors to share their information. They believe that the doctors in the U.S. are giving credible information. It's just some of them are not currently linked to care, or they don't have access to care due to insurance issues, et cetera. So that's something that we can work on as doctors, as being advocates for these patients. And then lastly, there are also trusted community voices outside of doctors that are also trusted in these minority groups. Things like religious groups um, are a really powerful avenue that patients get medical information from. So leveraging those partnerships between medicine and non-medicine trusted community voices is something we also are looking to do in the future. So, in terms of conclusions from this project, we have some key learnings, which I sort of delved into earlier, but as well as communication strategies. But I really want to highlight my particular takeaways from a medical education perspective, and just reiterating the power of our voices. So, as healthcare providers, we should not forget that our voices are very powerful and are very heard, especially in these marginalized communities. Thus, we shouldn't forget about these marginalized communities, especially in in a setting such as Sinai, where we have such a diverse patient population. We want to think about what our disadvantaged communities need from our advocacy, and sort of cater to their needs as well, which may not be the same as, certain more privileged communities. And then thirdly, it's never too late or early to engage in public health and advocacy. This is something that I really learned and took to heart as a medical student, working with in a collaborative approach in that sort of viral hepatitis elimination committee ran by the state. I thought we did a lot of great advocacy work. We went to Harrisburg and advocated for our patients, advocated for funding to eliminate sort of this public health issue. And then I want to thank IME and ERD for this opportunity. Another shout out for my Hep B Foundation team, and then a couple of publications that we were fortunate enough to get published this year. And then there's some also pending that we're still working on and wrapping up. That was sort of a very high level overview. I can leave my contact information if this speaks to anyone sort of on the call. I'd love to connect. This work is ongoing, and more broadly speaking, my work in sort of liver cancer, Hep B, and advocacy for sort of the disenfranchised, disadvantaged populations are ongoing as well. Thank you very much.
Thomas, thank you so very much. I'm going to actually pause for a couple of questions before we turn it over to Dr. Chada. First, I want to give a big round of applause for your work, and just incredibly powerful and meaningful, and what a beautiful arc of work to have started as a young medical student and continue. I think we're lucky to have you in the profession, Thomas. Any questions? If you could raise your virtual hand. I see a lot of claps for you, Thomas, so I hope you feel that. Any questions for? Yes, Noelle Marie, please go ahead.
Congratulations, Thomas, for this outstanding presentation. In your findings, were there any surprises?
I think there were certain surprises because we surveyed a lot of different minority groups. And being an immigrant myself, I feel like we, for example, surveyed like Korean or Chinese community groups where I thought, oh, your misperceptions kind of make sense because I come from a similar background. Things like, we heard from those communities, sharing of utensils when sharing a meal together, that could transmit hepatitis B, which we know is not true. So those are not as surprising, but when we surveyed a lot of the African immigrant populations, those misperceptions were very surprising to me personally because um, my exposure to those populations are fewer. So really hearing what they believe and what their barriers are to linkage to care, things like believing in traditional medicine and not believing in Western medicine, or a general distrust for the Western medical system, was a bit of a surprise, especially for some of these people have been in the U.S. for a while. So knowing that they've lived with Hep B without seeking care was a surprise.
Great, thank you so much. We'll save you additional questions. I'm going to turn the floor over to Dr. Chada. Go ahead, Nisha.
Great, thank you so much. Just going to get my slides up here. All right, can everyone see? Wonderful. Well, big thank you again to Dr. Karani, to Daniel, to the IME team. It's really a pleasure and a privilege to be able to share our work today. The title of our study is Applying Motivational Interviewing to Improve Glaucoma Management, a pilot study with ophthalmology residents. And I have no disclosures. In terms of the learning objectives, we hope that by the end of this presentation, you'll be able to describe the 5 A's model for motivational interviewing, which I will herein refer to as MI, not to be confused with what we traditionally refer to as MI, and how it can be adapted to one specialty, and to describe an approach to teaching and evaluating counseling skills with our trainees. So before we dive in, I'd just like to get a sense of who's in our audience and how familiar everyone is with motivational interviewing. And I humbly pose this question because I was not very familiar with it when I first set out to engage in this work. So if you're able to scan the QR code, I would love to hear your response. All right, great. So a little bit of a bell curve, which is great. Thank you for validating my talk today. And if you will indulge me one step further, and if you do use motivational interviewing, I would love to know how you use this in your practice. Okay, great. So the focus is, of course, using it to leveraging it for behavioral change. It looks like some have used it for smoking cessation, other counseling interventions. So really, it's a useful tool. And so for those of us who may not be as familiar, and as a refresher for those who are, what is motivational interviewing? So motivational interviewing is a goal-directed, patient-centered counseling style to elicit behavioral change by helping patients to resolve ambivalence. And so the idea is we as physicians can offer therapies, but it's incumbent upon our patients to actually follow through with these therapies. And so they need to have a certain degree of intrinsic motivation to make these behavioral or lifestyle changes. And that can be really challenging. And so this technique really tries to get at each individual patient's individual motivating factors for behavioral change and leveraging that to help them to kind of find that motivation to make lifestyle changes. And so this has been very effective in general medicine, as many of you may know. There's a lot of literature on its effectiveness in decreasing alcohol consumption and alcohol use disorder, in improving glucose self-monitoring, in improving medication adherence in patients with hypertension, and reducing or improving smoking cessation rates. So it's been very well established since it was developed as a counseling technique in the 1980s by Miller and Rolnick. And so what does this have to do with ophthalmology, and how did this whole project come about? So I was actually sitting in 1201, I think back in 2018, in ASM, listening to Dr. Jenny Lin's wonderful lecture that she gives to the medical students on motivational interviewing. And I had a total light bulb moment thinking, wow, I could really use this technique in my practice, especially when I'm talking to my glaucoma patients about using their drops. Um, and as many of you may know, medication adherence, and specifically eye drop adherence in glaucoma, is really a challenge for us. The literature suggests that adherence is around 60%, and this is corroborated by patient self-reported non-adherence data, which is around 30%. In fact, I found this one interesting study where they monitored patients. So patients knew they were being monitored for medication adherence, and almost half of them still use their drops less than 75% of the time. So that tells us when they're not being monitored, it could be even more poor. And so, you know, glaucoma is a vision-threatening and unfortunately cause of irreversible vision loss. And so we definitely have room to improve adherence to help prevent this condition. And so what I did next was go to the literature and see, you know, had any other ophthalmologists had this aha moment? And there wasn't a lot of literature on motivational interviewing in ophthalmology, but there's a few folks at University of Michigan who have done some work surrounding this. And interestingly, they employed motivational interviewing with what they refer to as paraprofessionals or health educators, with somewhat mixed results on improvement in medication adherence. But meta-analyses of the general MI in medicine literature have really shown that MI is more effective when delivered by a physician. So I thought, if we can leverage MI to improve glaucoma medication adherence amongst our patients, and if this is more effective when delivered by a physician, why not train and teach the future, our residents, on this technique so they can integrate it into their approach to glaucoma counseling for our patients? And so I shot off an email to Dr. Lin, who, as many of us know, wears a lot of hats, and she thankfully agreed to mentor me and collaborate with me on designing this study. And we actually wrote up a proposal, and we're fortunate to receive a grant so that we could really develop a very robust workshop. So I want to stop and focus a little bit on the study design, because I think this is where a lot of thought had to go into this, and also addressing sort of logistical challenges. And so one logistical challenge is we have the largest ophthalmology residency program in the country. We have 10 ophthalmology residents, which I love as an educator because our end value is quite large. But logistically, our residents go to many sites. They go to the VA, they go to Elmhurst, they're at New York Eye and Ear. So we had to get protected time to have all of them together in one place. And we knew we could only make the ask for one session. So we thought, how can we, in a rigorous way, measure the impact of this workshop when we only have the residents for one session? And so this is the study design that we came up with. We had all of our residents go through the workshop in real time at the same time, but we randomized them to go through a standardized patient encounter related to glaucoma counseling, either right before the workshop or right after the workshop. And this design allowed us to measure for change in approach to glaucoma counseling. And just for context, we actually did offer this twice. We did it once with our PGY1 residents who are interns, and we did it once with our PGY2 residents who are first-year ophthalmology residents. So our total end value was 20. In terms of the components of the workshop, there were three major components. We had an introductory lecture where we talked to our residents about motivational interviewing and the underpinnings and the data from the literature. And then we had two videos that they reviewed. One was with what we considered sort of standard counseling on glaucoma medications for patients, and then one that involved or used the MI technique. And then the workshop ended with role plays where residents had the opportunity to practice in pairs the technique that they had just learned. And so this is another overview of our study design that just includes the points at which we administered surveys. So we surveyed the residents immediately before, and this was the components of the surveys included knowledge and attitude type queries. We surveyed them immediately after the workshop, and then we conducted a 6-month follow-up to look at retention or self-reported retention of skills and knowledge. And so the development of the workshop materials is where we spent the bulk of our efforts. And so I wanted to take a moment to go over what we considered the 3 phases of our workshop development. And so phase 1, or bucket 1, I should say, was the video development. And so we had to develop scripts and a sort of standard script for glaucoma counseling, and then one that integrated motivational interviewing. And so to do this, we had to select an MI framework that we wanted to work off of. There's a number of different frameworks, and we chose to use what's referred to as the 5 A's framework, which I'll talk about in a few slides. And then we made sure to integrate these some of the key components of the frameworks into these scripts. And then finally, we had peer review by glaucoma experts and graduating residents, just to make sure that the standard sort of approach was a realistic representation of how residents might counsel patients on glaucoma and how glaucoma experts might do that. And then the fun part is we got to film them in the Morshan Center. The second bucket, or the second development phase, was the standardized patient case development. So we had to develop a case around a patient who was struggling with medication adherence, and we had to develop checklist items to measure how effectively residents utilized motivational interviewing in their counseling of this patient. So again, these checklist items were mapped back to the 5 A's motivational interviewing framework that we decided to use, that was demonstrated in the videos that they watched. And then we did SP, or standardized patient training, on these cases, so they knew how to grade our residents as they went through these SP encounters. And then the third bucket was sort of miscellaneous items. This included our pre and post survey questionnaires, our role play cases, and the overview lecture. And I'll note the role play cases actually weren't all glaucoma cases. We included some other cases related to ophthalmology where motivational interviewing could be used to demonstrate to our residents the utility of motivational interviewing even beyond glaucoma. So how did we adapt MI to glaucoma and develop these checklist items? So here I'll share with you the 5 A's framework that I mentioned we used. And the 5 A's include ask, advise, assess, assist, and arrange. And so basically, these are the underpinnings when utilizing motivational interviewing in any counseling sort of situation. And so we sort of came to a consensus on how we would interpret each of these in a glaucoma case. So for us, ask meant sort of finding a point in the conversation where we could explore medication adherence with our patient and how it was going. Advise for us meant an opportunity to educate patients on the nature of glaucoma. And I'll tell you, having been in practice and with glaucoma patients for some time, and also as a patient, we don't always glean or fully understand health information the first time we hear it. And so a key point in this framework was to revisit the patient's understanding of their condition, and maybe even employ a little bit of teach back to make sure that the understanding was there. For the assess portion, this is where the MI sort of piece came in. And this was exploring with the patient their individual motivating factors and potentially even barriers to adherence with their drops. And then the assist was where we tried to, in a collaborative way, ideate strategies to overcome these unique patient barriers. And then finally, arrange just referred to arranging close follow-up so we could track for progressive improvement in adherence, as this certainly is a journey and takes time. But the close follow-up is key to helping the patients incrementally improve. So we also wanted to give our residents some key takeaways that they could employ, let's say, the next day in clinic, because as many of us know, motivational interviewing takes a lot of time to master. And, we only had one opportunity in this short workshop. So we wanted to hone in on some key questions that residents could employ. And we refer to these as the scale questions. And so one question we shared with the residents to use is this: on a scale of 1 to 10, how important is it for you to treat your glaucoma? So this is assessing the importance of the behavioral change to the patient. And for most patients, their motivation is high to actually make this change. They want to stop smoking. They want to reduce their alcohol consumption. They want to adhere to their medications. But then the follow-up question to that is assessing their confidence. So on a scale of 1 to 10, how confident do you feel about using your drops? This is where they'll often have a lower score, potentially something like a 5. And this is where the magic of MI happens, because we sort of flip this seemingly low score on the patient and turn it into a positive. So we come back with, well, what made it a 5 and not a 3? And asking that question helps to elicit from the patient perhaps some intrinsic motivating factors. So for example, when I use this in my practice, often what I've learned is maybe my patients are professional drivers and they need their vision to maintain a professional license to drive. So that's something we can really rally around to try to engage the patient and improve motivation. And so again, these were two kind of key items that actually were on our checklist as well that we wanted to teach our residents as key strategies when using motivational interviewing. So what did we find? I'm going to share with you here our pre-survey findings. So we started in the pre-survey by asking our residents how familiar they were with MI. And not surprisingly, 75% were familiar with it. So they had probably received some sort of overview lecture in their medical school training. And this was interesting. We asked if they used it, and I was surprised to see that 47% said they were using it when counseling ophthalmology patients. Now, for context, this includes 10 PGY1 residents. So they're a little bit closer to their undergraduate medical education and maybe we're a little bit closer to this technique. But this is sort of where we started in the pre-survey. I think this is the most remarkable finding in terms of our results. So this is the scores on their SP encounter, their standardized patient encounter, control versus intervention group. And this is based on their scores on the checklist items. So interestingly, the control group, and it wasn't very different across both cohorts, the PGY1s and the PGY2s, both scored an average of about 62% on our MI checklist for the standardized patient encounters, so not really using too much MI. But this improved after this brief 90-minute workshop to about 82%. And this is not reflected in the slide, but our sub-analysis of MI-specific checklist items, so where we looked at asking questions like the scale questions, showed that only 12.5% of the control group used MI-specific items, and this improved to 75% in the intervention group. So we were very pleased to see this improvement, which was statistically significant. And then I wanted to share some more qualitative data. We had in our pre and post surveys 2 glaucoma counseling cases that we queried our residents on, and we asked for their approach in a narrative format. And we did a qualitative analysis on their responses and coded them based on the 5As. And so the blue columns show how many times one of the 5A codes came up on the pre-survey versus on the post-survey. And you can see remarkably assist, and we subdivided the assist, which is identifying strategies to overcome barriers, into 2 subcategories. But you can see that this significantly improved following the workshop, and that really is kind of the heart of MI is identifying barriers and helping patients to overcome them. In our second case, which was similar, most of the categories also increased. We saw increased frequency of these codes in their responses, Interestingly, advise, which is the educating the patient piece, decreased. And I just wonder if that's because residents spent more time on identifying ways to improve adherence rather than re-educating patients on the nature of glaucoma. But definitely an improvement in these codes on these qualitative queries. And then in terms of self-reported confidence on a 5-point Likert scale, confidence was kind of in a bell curve prior to the intervention, and it improved following it. And in terms of the workshop itself, it was well received. Residents recommended that this be offered in the future, and most of them plan to utilize this technique in the care of their patients. So the 6-month survey data was very interesting as well, and we really would have loved to do a follow-up standardized patient encounter to really measure retention of skills, but unfortunately we weren't able to get protected time for that. But we were pleased to see that our residents reported using MI frequently, with up to 50% of residents using it weekly. So I always like to close with medical education projects and link it back to our patient care and our patient outcomes. And so this is sort of data that I share when sharing this project in ophthalmology forums, hopefully to get buy-in for our efforts. But how does all of this relate to improving patient care? And this was an interesting study done by a group where they looked at visual field data. So as some of you may know, with glaucoma, when intraocular pressure is high, patients lose peripheral vision. So we measure their peripheral vision with visual fields, and poor visual fields obviously are reflections of less well-controlled glaucoma. And so they looked at visual field data and they looked at pharmacy data and created a model to look at rates of progression. And basically they found that if adherence based on pharmacy data improved from 20 to 80%, you could slow down glaucoma progression by a year. And that's huge for us because glaucoma is a chronic disease that is slowly progressive. And so we're just trying to buy time. And even a year of time is very useful because, it helps to save our more aggressive interventions like surgery, et cetera, and sort of delay that for our patients. And then, cost is always important. This was an interesting study done in a VA population where they received a counseling intervention, and they looked basically at quality of life and cost. And they reported this in a cost effectiveness ratio, but basically found cost savings and increased quality of life with this behavioral intervention, which improved medication adherence. So basically, incorporating motivational interviewing could slow down glaucoma disease progression, could increase quality of life, and could increase cost savings. And, the final thing I'll note is when we made these videos, we intentionally made the length of each of them the exact same to demonstrate that using this technique could be effectively administered in the same amount of time as sort of standard glaucoma counseling. So I just want to close with some acknowledgments. A huge, huge thank you to Dr. Jenny Lin, who was an exceptional mentor through this process. The New York Eye and Ear Eye and Research Vision Institute for their generous grant support. Everyone at the Morshan Center, Terry, Nikki, Megan, who were instrumental in developing these videos and the SP cases. Our New York Eye and Ear education leadership who supported this work and provided protected time, and all of our residents who participated. And finally, I just want to thank my kids. I started this when my now 3-year-old was just born. He had a little sister along the way, and we just submitted our manuscript for publication 3 years later. So a labor of love. But thank you so much again.